Hello everybody, my name is Bogdan Goga. I'm a Romanian physiotherapist. I'm implicated in the OMTRO program, which is an orthopedic manual therapy program running in our country. And with me, it's an esteemed colleague from Greece, from Athens, involved in the Hellenic orthopedic manual therapy and also in the Romanian orthopedic manual therapy programs. Hello, Kostas.
Hello.
Mr. Kostas Sakerariou has a great experience with orthopedic manual therapy. And I will start directly with the subject saying, Kostas, you say manual therapy rocks. But I've seen, and we see nowadays, a lot of colleagues of us that say manual therapy sucks. So why is this big difference from rocks to sucks?
Yeah. Good question.
Yeah, it's a funny one, but it's a good one, isn't it?
Yes, I think it's a funny one. But actually, look, if we think about what is manual therapy, the big problem is the definition. What do you find by saying manual therapy? For example, we hear some people saying that manual therapy is good for that or not good for that. For me, saying manual therapy is good for treating, let's say, low back pain has the same value with saying manual therapy is not good. Because manual therapy is not one thing.
Yeah.
So you have to define what do you mean by manual therapy. In my opinion, it can be that people really don't know what manual therapy is. I don't know. I cannot talk.
Do you think that the persons that say that are against manual therapy really studied manual therapy?
I cannot tell you because I don't know everybody's background.
Yeah.
I think that
can you have like to try to have an objective opinion if you did not study it?
Well, I believe that the people think that the hands-on approach is not, let's say, correct, it's not valid, it's not scientific, I don't know. The thing is that we already know that there are a lot of limitations with our techniques, with our hands. We know that.
Yeah.
We know that many years ago, before the people started in the media, let's say in Facebook, quoting that manual therapy is not good, is not valid, or it sucks, or whatever. We know the limitations. But manual therapy has evolved throughout time. And if you evolve, you get better. If you don't evolve, you get stuck, you're not scientific.
Yeah.
So we know the limitations of, for example, the reliability of some technique with palpation. But you know, it's like a pendulum. You don't have to go from one end of the pendulum to the other end.
Yeah.
It's not black and white.
Definitely.
So what I think about manual therapy is not only the hands-on, is the whole way that you approach a patient. It's the decision making, it's the clinical reasoning, it's of course the evidence that it's there, and moreover it's the common sense. So everything has to be combined in order to try to use the available evidence
from each concept. So
I don't speak about concepts. On the contrary, I think that concepts have more limitations, because if you follow a pure concept, only one concept, okay,
it doesn't matter.
No matter.
We can quote like Jeremy Lewis: if it starts with the M, definitely it works.
What's up, bud?
If it starts with the M, the concept,
okay,
the letter, the first letter of the concept.
Okay.
If it starts with the M, then definitely it works. You know, massage, manipulation, and stuff like that.
That's a good one.
Mobilization.
That's a good one too.
Yeah.
Well, all the concepts have their limitations, and when something is proven by science that is not working, usually the concepts have the tendency to protect the product. That's why they don't evolve.
Yeah.
That's my opinion. If you just follow, you can take from every concept you can take some good things, because everybody has put his own experience in his concept and his own good things and still work. What I strongly believe is that we use more or less the same techniques, for example, that we used to use the previous years. But what has changed really and dramatically is the explanation.
So we know today that we're not putting things back into place.
Yes. We know that. We know that many years ago. We know that, for example, if we just maintain a position in a technique for some seconds, it's not the creep phenomenon that takes place and you have improvement of the movement. There are some other mechanisms. Yeah. So we use the same things more or less. So my objection to people that just go around and only see the negative things about manual therapies, I would really be very, very curious to see how they treat patients like fractures. Like limitations of movement. Because if you only talk to people with pain, okay, you can talk, you can train. Of course, training and exercises should be a part of the physiotherapy session as soon as possible. But there comes a point that you have to put your hands on and feel some movement. And we know that there are limitations. We know that we don't have good reliability in everything we do, but actually we're physios. We're not poets.
Yeah. But also these limitations are in every aspect of medicine, because this is the idea. It's an applied science, it's not a strict science.
Yes.
So
we're not structuralists. We know that we're not structuralists. We don't treat the structures. We try to improve the movement. We try to improve the function. We try to encourage the patients. We try to educate the patients. But we have to do it in a humble way and in a way that does not, first of all, offend the patients, does not reinforce the myths that are around, and uses the available evidence. And again, I say the common sense.
Yeah, we should use the biopsychosocial model, but what I've seen a lot nowadays, that it's used this biopsychosocial model, but it's really excluding the biomedical. It's only psychosocial thing. So I think we should never exclude the biomedical and the biomechanic. We just have to put them in a context also with the psychosocial things of it.
The important thing to understand for everyone, for every health provider, is what a previous former president of the WCPT, the World Federation of Physiotherapists, said, is that the patient has one diagnosis. So if you are a patient, if I'm a patient, I have one problem. If you are a McKenzie therapist, if I'm a Calderborn therapist, or if I'm a chiropractor, the patient has the same problem. It's the professional's problem to identify it. So if we don't have the ability to find the correct diagnosis, that is our problem. It's not the patient's problem.
Yes.
Every patient comes with a certain problem. So we cannot, how we call it, we have to be clear in this diagnosis. And if different people examine the same patients, we should be able to make the same diagnosis.
Yeah.
So we should get rid of our biases, and we should find a terminology that is functional for the patient, and it's also in accordance to the evidence. That is why I say that we don't have to have a structural diagnosis only.
Yes.
So like a disc hernia, whatever. Okay.
Yeah. That's my problem.
Okay. That's my point.
Yeah. Can understand this. So we know nowadays that we are moving to some may propose the idea of OMT moving to musculoskeletal physiotherapy, not to call it like that, because we know that now in the OMT approach, we don't just do hands-on techniques. We assess patients. We have a clinical deductive way of thinking. We elaborate hypotheses about their, let's say, pain or restriction or problem, and then we set up clear therapeutic goals. And if some manual techniques are in help, we may use them, but we also prescribe exercise. We also do therapeutic exercise. So it's not only putting the hands on the patient.
Yeah. Well, I just thought about that. If you speak about how we were defining our profession or OMT before, and you see orthopedic manipulative therapy or orthopedic manual therapy, this was defining the tool we use, our hands.
Yeah.
But when you shift and you define the profession like orthopedic musculoskeletal, it's about what patients do you treat, or what is your specialization. So you move from what you do.
Yeah.
The OMT moved from manual therapy, which is showing that you use your hands only, to musculoskeletal patients, musculoskeletal therapist. So that means that you have shifted towards
the population that you treat.
Yes, you're treating musculoskeletal problems, not by only applying techniques with your hands.
Yeah.
By doing massage, by doing exercise. Not only massage, of course,
Yeah.
but for me, manual therapy is also to use massage for some patients.
Yeah.
Because they need it, because the mentality, for thousands of reasons I can do that.
If the patient needs it, and
Yes.
and your clinical rationale says that in this moment, this can really bring something better to help the patient become better in his life. Definitely, we will not stay only with massage, because this is something that
Yes, that is a curse
the
of our
persons
profession.
that advocate against manual therapy says that we should not use only passive treatments, and we should not make patients dependent on us.
That's right. I fully agree with that.
Yeah.
But there is another side of the coin. I will give you a personal experience. So I once tried a patient that had not, let's say, pure musculoskeletal, let's say. So he had kind of dependency and expectations. He was more like a chronic pain patient. So when she liked to be treated by me, and I was trying to tell him that, look, we can do some sessions, but actually you don't need physical therapy in the way you thought about you need. Once I called him some months later, he told me that I felt that I was turning my back on him.
Mm-hmm.
So you have to think about the patient as a whole personality. And we're not treating joints. We're not treating chemical substances in the body. We're treating human beings. And when we're talking about human beings, you're talking about the mentality. You're talking about the country that he lives. You're talking about the mentality in the country, or even the changes in the mentality in different parts of each country. You're talking about a certain health system. So we're talking about many parameters that you have to take care of.
Yes.
So we cannot take somebody who works, for example, in Denmark and put him to Greece and expect him to be successful if he takes the same way of working from Denmark and bring it to Greece, and vice versa.
Yes.
So we have to think about many things when we treat our patients.
Yeah. Take them and apply them where we live and to our own system.
Yeah. Well, the target should be the same. The target should be, as principle, don't work passively only. Don't spread the myths and make the myths bigger and stronger.
The healer.
And all the myths, yes.
Yeah. The putting back the bones, the bone settlers.
Don't do that as a principle, but use what is available and then how to communicate it. The more important thing is how to communicate this to your patients. You cannot just go there and in an arrogant scientific way just say to your patient that this is totally wrong or whatever. You cannot insult the people.
Yeah. Kostas, I think we had a very nice conversation, and hopefully the people would enjoy.
Let's see.
Yeah. So thank you guys so much for watching. We are waiting for your comments or ideas of discussion. And stay tuned and watch our YouTube page and also our Facebook page for more podcasts like this.
Thank you, guys.
Thank you.